welcome everyone. We are here with Dr. Laura Esserman, who I had the opportunity to meet at TEDx Berkeley last year when she graced our stage talking about her latest work with her wisdom study around breast cancer, which we're going to talk about today. But before we get started, I'd like to give those who are new to your work a little bit of background about who you are. Dr. Laura Esserman is a nationally known breast surgeon and directs the UCSF Carol Frank Buck Breast Care Center. Her work is devoted to developing new and more effective ways to care for and empower breast cancer patients during treatment. She tailors treatments for individual patients using biology, personal preference, and constant feedback regarding outcomes of care. Recently, she launched Wisdom, a groundbreaking study that transforms the way women are screened and treated for breast cancer. She and her team hope to bring a more personalized approach to figuring out each woman's risk for the disease and tailor a screening and treatment program appropriate for that risk. So thank you for being here. I am so excited to share your research and this approach with the world.
Thanks so much for having me, Renee.
So before we get started on your current work, I'd love to rewind the clock just a little bit. Talk about a couple of your aha moments following your studies at Harvard and Stanford, when you realized that some of the traditional medical systems were either insufficient or in other cases broken. Can you talk to us about some of those early insights?
Well, I think there have been several insights that I've had along the way, and I've had the great fortune to work with a number of really pioneering people in medicine. Ron Levy, who was my mentor, is an immunologist who has transformed the field of immuno-oncology using monoclonal antibodies for the first time to treat lymphoma. And even though that's not necessarily a surgical disease, I was able to view up close how a true innovator approaches a problem. And he felt like traditional chemotherapy was not the solution to low-grade lymphoma in particular, and that it was fairly toxic and people would get recurrences. And so he wanted to come up with something better that he thought was based on the biology. And this was super important to me. I also had so I learned really how to approach a problem, how to think differently, how to take a step back and say, wow, are we doing the right thing? Can we do something better, smarter, and less toxic? I also had the good fortune to work with someone called David Eddy, who was doing was training as a heart surgeon and decided to go into engineering economic systems and work on disease modeling and really start thinking about, what is how do you model the rate of disease and sort of think differently about screening. We were working on cervical cancer screening. And I had the unfortunate experience of saying at the time we had predicted that you really only needed to screen every 3 years. And that by screening more frequently, we didn't actually have the workforce. And so you would have more false positives, more false negatives. It actually would be net a negative. But when I tried to bring this back to the clinicians, they were like, oh, well, women can't possibly remember, to screen every 3 years. So I think I'll stick to every year screening. And I was so upset and dismayed by this. I thought, okay, forget policy. I'm just going to work on science. And that's when I moved to Dr. Levy's lab. And, at some point, Alan Enthoven recruited me to business school. It was just one of these unexpected right turns in my journey that, I just decided to accept. And, I really learned how systems work, how ideas become implemented, how to help get your ideas accepted and move forward. And I think these really made a difference. And then kind of influenced by people who were fairly fierce in their approach and their steadfastness. People like Nancy Asher, who was the chair of surgery for many years, who was a first woman transplant surgeon, and people like Jackie Spear and Nancy Pelosi working for what women needed. And I have to say, the people who inspire me most are my patients. When you sit across from someone and you offer them a choice and they look at these choices and they do not like the choices, your work is not done. Just because this is what you've learned and this is the standard, you have to think, why don't they like the choices? Pretty obvious. They don't like surgery, they don't like radiation, they don't like chemotherapy. Can you think about, again, can you think about what makes more sense? And, I think influenced by what happened in prostate cancer, that, every disease is not one disease, it's many diseases, right? And there is a spectrum of biology from ultra low risk to, very fast growing, slow growing to fast growing, and some really fairly indolent, not going to go forward and not ever cause a problem. And when you screen, you necessarily are going to surface more of this reservoir of very indolent disease. So you can actually inadvertently, not intentionally, but inadvertently put people in harm's way by doing too much intervention for what they need, not the right intervention. I always like to say we want to do the right thing at the right time for the right person. And I would say, there was a Gordon conference sometime in the early 2000s that I was attending. And there were two things that I think really struck me. One was that, in ovarian cancer, sometimes very large tumors don't necessarily kill people, and small tumors really can. So again, it's about the biology, not the size, that we have to think about that. Two was that I was looking at colon cancer rates. Brian Reed was talking about how, the colon cancer rates were going down. So colonoscopy, finding polyps, doing things, that this was causing a drop in the invasive colon cancer rates. We've been screening and finding precancerous lesions like DCIS and finding more and more of these small grade tumors, smaller size, lower grade tumors. But the incidence rates of late stage cancer was not dropping at a concomitant rate. And despite the precancers being taken out, now like 60,000, 50, 60,000 a year, we have not dropped the invasive cancer rate. So just by the math, you have to say, okay, there's something wrong. And it's not about, it's not about saying, oh, screening is wrong. It's, wow, how can we make it better? How can we be smarter? Because we spend billions and billions of dollars, well over $10 billion today. We've just re-looked at this issue. It's probably $15 billion that we're spending on screening now. And for that, what are we getting for it? Can we be smarter? Can we do more for the people that need it? And decrease the burden of screening for those people who are lower risk. I am certain that we can do this. We know we can do this. But it runs up against 30 to 40 years of public health messaging is find it early, go get your mammogram at 40 and all will be well. But all is not well. All is not well. There are problems and we must face them and figure out how to make it better or we're not going to have any change, right? And I always like to say that, people are like afraid of clinical trials. Oh my gosh, how could I be in a clinical trial? Clinical trials are tomorrow's treatments today. The only way we make change is to try something different, but to test it in a rigorous way so that everyone can benefit. And, if women didn't have the courage to participate in trials of breast conservation versus mastectomy, and by the way, they're the ones that drove it. They're the ones that demanded it. We would still be doing radical mastectomies today. Yeah. This is like, sometimes the answers are surprising, but you have to look at the data. You have to constantly say, how can I do it better? How can I do less and still make the outcomes just as good? As we learn more about the biology, how do we tailor to the biology? How do we think about what people are at risk for and do better? That is what we need in medicine.
Well, you're also talking about a whole systems approach. With all of this, you're saying that cancer is not just one disease and how all of these diseases have something in common, right? And they're related and interconnected to each other because our body is a whole system. It's not just this one, it's not just heart disease and it's not just cancer over here or, breast cancer over here, right? And so this whole system approach is also something that it seems like you're trying to get awareness about as well, that you can't just focus on one thing.
Well, I think when you take care of somebody, and someone comes in, they're not their breast cancer, they are a person. They come in with a particular condition, a risk, either they're at risk for, or they have a new cancer, or they're progressing with breast cancer, but they then come with a set of health conditions. And they actually come with a set of social conditions and preconceived notions and anxieties and fears and hopes. You have to actually put it all together to be a good physician. That's the art of medicine, is trying to put all those pieces together and trying to figure out what's right for that person. And then saying, well, I try at our breast program to have a menu of options, all of which include trials.
Yeah.
And those trials are our hope of what we want the future to be. And we want the future to be, well, let's try this. If that doesn't work, let's try this. And so I've worked very hard in our 𝐼-SPY trial to make it be, we're starting with what we think are these new, exciting antibody drug conjugates, maybe get us away from traditional chemotherapy. If they don't work, okay, then we're going to go and give you the best treatment for your particular subtype. And with my colleague Laura Vanfier and this whole amazing team of researchers, we've actually figured out how to better categorize tumors. Some are driven by the immune system, some are not. Some are, driven by DNA repair deficiency. Some are, are hormonally driven, and we still haven't figured out what necessarily that switch is. But we are going to do much better by better understanding what is driving those tumors, and then for those, start figuring out how to keep pushing on the system to make it better for those. And by the way, that also informs the whole field of precancer. It turns out that there are some people who have lots of lymphocytes in their DCIS, that precancer or in situ cancer, that if those lesions that are hormone negative or HER2 positive, which people haven't actually even looked for in the past, it stands to reason that if you've got precancerous changes, then that often looks like the cancer that you are going to develop. That is a window for prevention.
Yeah, huge.
It's a window to understand, wow, guess what? The biology of precancer reflects the biology of invasive cancer.
Right.
These three cancers are a window to think about, wow, how can I prevent progression? Don't just operate and take it out. When you do that, guess what? That's all you ever get. If people want change and they want something different, you can't keep doing the same thing over and over again and hope that it's going to get better. It just doesn't work that way. And we're running this trial now where we're doing in situ vaccines for people who already have, who we think are predisposed to getting these immune cancers. And it's very exciting. We're starting to make stuff go away. It's like exciting. It's the beginning of that change, or if someone has hormone driven in situ or precancer, start with 3 to 6 months of endocrine risk reduction and see what happens. Not everybody needs surgery. We have a number of different trials going on around the country to try and get us away from one size fits all.
Right. That's the other thing I was going to bring up here, is that on the surface, at least to some, it appears that your approach is radical, but really when you look at it, it's not radical at all. It's simple. It's personalized care.
It's rational.
Yeah, it's rational. It's personalized care, right?
And, and we all want personalized medicine. We all want precision medicine. And then, but that requires you to say, gosh, I'm not going to do the same thing for person A and B and C, because they likely have different disease. You have to take into account that person and that person's sensibilities and their overall health status when you try to think about it. And we try to think about that in our trials. Someone was saying the other day, wow, it's scary to participate in a trial. I said, well, not if the trial's designed right. If you design trials for what people are interested in, I designed some of these active surveillance trials for people who really did not want to start with surgery. And they've taught us so much. If I didn't listen, I wouldn't have learned. And I can couple that with different ways of imaging using MRI imaging. And, my partner, Nola Hilton, and I have been working on this together for 30 years. She is an amazing person. She's an MRI physicist. And in 1993, we were both starting on the faculty, and she was writing the sequences for breast MRI.
Wow.
What became breast MRI. And she came to me and said, could you use a tool like this? And that was the beginning of a 30-year journey. And I said, well, let's take the people with these big, high-risk, terrible cancers and see if they all look the same, which they did not. And then let's start with the systemic therapy first, and let's see if everyone responds the same, which they did not. So you have to say, gosh, why are we treating everybody the same? The standards are, if you have this kind of cancer, you have surgery, and then everybody gets the same therapy. But that makes no sense
because we've never really traditionally gone with this whole system approach to medicine. So what is the biggest resistance that you've gotten, from where and why?
Well, so we've made a lot of progress. And I think the standard of care for some of these big cancers is to start with systemic therapy first. I mean, that's taken us 10 to 15 years, which is, it's not just me pushing that, but a number of people all over the country sort of pushing this and saying, gosh, this makes sense. We've got to have an idea of who's responding or not, because if you have a great response, you can do less. And if you have not as good a response, you can be forewarned and try and do more.
Mm-hmm.
Now, if it doesn't make sense to treat everyone the same with breast cancer, does it really make sense that we should be screening everybody the same? Does that make sense? Why are we screening everybody as if one size fits all, and as if every woman has the same risk for breast cancer and for the same type of breast cancer?
So where is the resistance coming from?
Well, I think that it's the power of public health messaging. 30 to 40 years, get your mammogram, that's it. I think some of the resistance comes from a good place. Mm-hmm. They're like, oh my gosh, if people don't go get their mammograms, we're going to lose ground, and you're going to be responsible for the death of all these people if you get people to stop screening. So I think it comes from a place of true concern, and so I understand that. Mm-hmm. But I have to say, I'm not trying to get rid of screening. I'm trying to make screening more precise, more rational, more tailored to biology. And more importantly, to integrate it with prevention. And so by doing that, so our story is, let's start with risk assessment. Let's find out what people are at risk for. Now, people would say, well, you have no idea. But actually, that's not true. There are some things we absolutely know. We know that if you inherit a mutation in one of 9 genes, you are definitely at higher risk for breast cancer. Some as high as 85% risk, some maybe more in the 35% risk. BRCA1 and 2 were cloned in 1996 and 1997. It is 2022, soon to be 2023. It is time for us to put that into action. This is part of the wisdom study. And by the way, we didn't say, oh, our way is the right way. We said we're going to test it. We're going to test personalized screening against annual screening starting at 40, because that's what the American College of Radiology says should be done. And that is what a lot of oncologists push. That's what, Komen pushes. That's what a little more nuanced American Cancer Society is pushing. Everybody's saying, because that's it. Well, go get your mammogram. And now that the pandemic is over, people are like, oh, go get your mammogram. But I will tell you, the people who got into trouble during the pandemic were the people who had a mass and didn't come in. Mm. Those are the people who really got into trouble, because those are the fast growing cancers. And trials like the I-SPY trial, where we treat people with stage 2 and 3 breast cancer, we wouldn't have such a trial if screening was catching all those people. Those are people in their 30s, their 40s, sometimes their 60s. Those are tumors that come up between cancer screens. There are fast growing cancers and there are slow growing cancers, and we shouldn't lump them all together.
So when you say fast, do you mean within a year period? Because COVID, 2.5 years?
Yes. No, I mean, you can, like someone with a HER2 positive cancer or a triple negative cancer, that can grow in 6 months. So we have this old notion that it takes 8 years for a cancer to grow. That could be for a slow growing, hormone positive cancer. But for these triple negative or hormone negative or HER2 positive cancers, these go fast. Now, fortunately, we really know how to treat HER2 positive breast cancer, so most people don't have to die of that disease. And triple negative, we're doing much better on as well. But we have the opportunity to do more, to do better, and to make it less toxic. So that's the drive. But we should start thinking about it. Well, who's at risk for those kinds of cancers? So the couple of things that we've learned from the Wisdom study, and we have now 45,000 women as part of this trial. This is a big trial. It's open to anyone in the country. Anyone from 40 to 74 can just join.
So for people who are new to this, let's just talk about it. So the Wisdom study, this stands for Women Informed to Screen Depending on Measures of Risk.
That's right.
So let's just introduce people to that for those who are new to it. You started it, and who can get involved?
Anyone who has not had breast cancer or ductal carcinoma in situ is eligible. And when you go to, it's at the, you don't have to go any place to get your care. It can be anywhere in the country. You go to wisdomstudy.org and you will get introduced to the study. And my TEDx talk is actually on the site, so that's exciting. You have a choice. If you're not sure what's best, let us randomize you and assign you one, either the annual screening or the personalized arm. If you're not comfortable with that, we still want you to join. And you can go to the observational arm where you can choose. If you say, look, I'm only going to do annual screening, I'm just not comfortable doing anything else, then choose that. If you say, I'm actually really interested to learn, and if I get that information, I'll actually be willing to take your recommendation. And at the current time, we are within one of the guidelines, either the American College of Radiology or the US Preventive Task Force guidelines. So the least you would get is every other year screening starting at 50. But our notion about this is that you can take all the information that we've learned. So we get the information about your genetic or the genes that you inherit. And how do we do this? When you sign up, if you're in the personalized arm, a little box will come to your mailbox and you open it up. There's a little kit that you spit into, put the top back on, put it back in the box, and off it goes.
So is this similar to 23andMe?
It's similar to 23andMe, but it's quite different in the sense that the actual genes, the 9 genes that are responsible for risk associated with breast cancer are sequenced. That does not happen in 23andMe. 23andMe cannot tell you about those genes, and it does not tell you about BRCA1 and 2. That's actually very important. 23andMe can report out on maybe 3 of the 1,000 types of mutations you can have in BRCA1 and 2. So a lot of people think, oh, I'm negative for BRCA1 or 2, and they haven't really been sequenced. So I think that's an important difference. We feel it's critical. There's maybe 1 to 2% of the population that has these mutations, but why aren't we finding them? We know about this.
Is this purely genetic?
That's genetic.
Have these mutations, or is there some lifestyle issues that contribute to people having them?
So this is purely genetic, but nothing is truly purely genetic. There are other things that you can do to influence them, and I'll get to that in a minute. And in fact, the other genes you inherit also influence that. So there's another set of genes that these are polygenic risk. So there's a background of genes that we've learned that also influence whether or not, even if you have a mutation, it can mean the difference between 40% or 80% risk. So a big wide swing that might change your mind. And we know, so if you're BRCA2, you might, or CHEK2, you're at risk for a hormone positive cancer, and maybe you don't want to think about prophylactic surgery and you want to think about endocrine risk reduction or, et cetera. There are lots of lifestyle things that you can do to reduce your risk, which, by the way, are good for you no matter what. They're the same things that Dean Ornish talks about. They're the same things that are good for colon cancer. It's the same things that are good for heart disease. Taking good care of yourself, exercising more, eating more of a low-fat diet, and a more plant-based diet is good for you. It's not, you can't ever violate this. You can have some, but you just try and have that kind of approach. It helps you in every way. It's good for you and good for your health in every way, right? So What we do also when we find that people are at high risk is that we have this whole counseling program. We reach out to people who are in that high risk group, and we have a tool called Breast Health Decisions that we take people through, go through all the lifestyle things, if it's appropriate to think about endocrine risk reduction. And one of the great things we've learned now is that we can use much lower doses of the medications, like a drug like tamoxifen. People were so afraid of it. We can use what we call baby tam, and that works just as well. Even if you're older, the aromatase inhibitors, now we can actually do this 3 times a week. And, there's lots of things that we can do. And we are devoted to finding better options. There are other things that we can look at. People are interested in looking at testosterone. People are interested in looking at, any number of different combinations. There's 8 or 10 of these on the market. This is so exciting. We have to make prevention a priority. Can you imagine if we could identify that 10%, 5 to 10% of people who are really at risk, where we could actually cut the risk in half or maybe 3/4, and we can figure out who those mutation carriers are? What if we cut the risk of breast cancer, getting breast cancer, in half? Like, how fantastic would that be? And everybody doesn't need it. We're not going to take the person who has like a 1% lifetime risk and tell them they should take a medication. That makes no sense. But people have accepted the notion that if I have a family history of heart disease, my cholesterol is high, I'm going to take statin. And has it worked? We have dropped the risk of heart disease through lifestyle measures, through statins, and all these combinations. We have dropped this in half. And I have to say, I envy the field of heart disease. I feel like the reason we aren't there in breast cancer is that people haven't made it a priority. We know enough to start thinking about it. There are exciting things that we can do. If there's a really small group of people at risk for these faster growing tumors, let's focus on it. Let's figure it out. Maybe the antiprogestins. There's lots of things that we can do to try and figure this out. And maybe this has to do with other things that connect in our lives. Maybe this is how we should be rethinking, the tools that we're using for contraception control, that we know that reduces ovarian cancer risk. Maybe we should redesign them to make sure that they drop your risk of breast cancer as well, because they were designed well before we knew any of this.
That would be amazing, right? That would be amazing.
Well, of course, but we have to, you have to aspire. You have to aspire to better and think differently. These are things that can be done, but they can't be done if we keep doing the same thing. Over half the women who had mutations didn't have a strong family history of breast cancer.
Oh, wow.
Okay, that's not a good enough screen. And we have the tools to screen. It's cheaper than a mammogram. Why aren't we doing it?
Well, what would it take to overcome that resistance? And who are the key players that could really make a difference, not just in explaining the awareness of the study, but changing the approach of screening altogether? I mean, obviously the Wisdom Study is trying to do that, but who are some of the key players that might be getting in the way right now that could assist in changing the paradigm here?
Well, I hope that we will be able to get the established groups to really embrace what we're trying to do. I know the U.S. Preventive Task Force is actually paying attention to our trial. We've gotten a safe to proceed, so we're obviously not causing harm just in running the trial. That's actually a really good sign. The American College of Radiology is, fairly opposed to changing the way we screen, but I'm hoping that as they see this, that we are actually on the side of trying to make screening better. Doing lots and lots of biopsies for someone who really doesn't have risk, it's a pretty terrifying experience for people, and they find it very traumatic, and that makes them actually not want to screen. We actually have the tools now to do more. There are, AI tools, to look at mammographic densities. There are all these kinds of things that we can start to put together. We have this big, what we call a program project that we've assembled to say, we're going to build better screening models. We're going to look at the information, all the information we have at hand, from the mammograms, from the genetic information that we can start thinking about fast growing, slow growing, that we can put all this together, and that we're going to run this continuous learning cycle. every few years, we're going to change the algorithm and see, do we do a better job? Are we finding the ones that we predict as fast growing? Are we like correct that the people who we predict have extremely low risk don't have much risk? And we can safely de-escalate there. We actually have the resources in the system to do a lot more for the people at highest risk, especially if we reduce the burden of screening for the people who really aren't going to benefit. And then more importantly, we're going to use this precancerous state as our gateway for prevention. This is our proof of principle. This is the kind of tumor you have, and we're going to start developing better, more tolerable treatments for prevention and start understanding, with through science, what are the pathways? What are the things? Things we can manipulate? What pathways have we missed? How can we figure this out? Test it again, not by just doing things and hoping for the best and waiting 5 years. Don't operate because it's not an emergency. Try these things first for a few months. If we can do it for invasive cancer, we can do it in the precancerous setting, for goodness sakes. This is how we short circuit and accelerate the pace of change. Everybody should want something better tomorrow than they do today. I always like to say to people who are afraid to do anything new, I'm like, well, do you use a cell phone? People say, well, of course. I'm like, okay, well, you're not saying, well, I won't use a cell phone, or I'm going to use the old brick Motorola phone that we used to use when I was an intern. That was the only thing you had options to. People like things that make their lives better. Be open. And it starts with every woman. It starts with every woman. Every woman is being told that they should screen starting at 40. Really? Well, as we start saying, well, look, we can do the genetic testing at 30 and start finding those young people at risk right away. It's 1% of the population, probably, maybe 2%. Every woman should aspire to better. Every woman should join us in this movement of saying, wow, I want the future better for myself, for my daughters, for my mother, for my friends. That's, if women didn't demand options for breast conservation, again, we would still be doing radical mastectomies.
Yeah, no, for sure.
Really, it starts with us. It starts with us.
But what about fear? So let's just talk about that a little bit, because I agree with you. And when you're thinking about generational, it's like, of course, I would want that for my daughter, right? But there's people who don't do 23andMe because they're worried about the results. They might worry that, will genetic test results become part of my medical record? And then I've got a pre-existing condition and insurance won't cover me. So there's a lot of these fears that women have, even though they obviously want this from deep down at a level.
Well, that's a great point, Renee. But it turns out that the Healthcare Portability Act says that, today with the Affordable Care Act, you cannot be discriminated against because of a pre-existing condition. There's something called the GINA Act that says you cannot be discriminated against because you have genetic predisposition. I think that people need to embrace the idea that this is just information. It's just another piece of information that it's just like knowing that you're at risk for heart disease and you can do something about it. These are things that you can do. Don't be afraid of it. It's something you can embrace. And it's pretty unusual to have. Again, one of the things that's pretty cool is, when we first discovered this, people were like, oh, you have to be careful. Don't tell anyone it's going to ruin their lives. Well, guess what? Now there are actually specific drugs, that we can use to treat it. Doesn't, just because you have a mutation doesn't mean you have to have a prophylactic mastectomy or a prophylactic oophorectomy. Although, once you've not giving, not going to have children, it's pretty hard to screen for ovarian cancer this time. So there isn't really a good reason to keep your ovaries. And that's a pretty low price to pay. But we now have drugs specifically where 70% of women with PARP inhibitors alone have their tumors go away. And we can figure out how to potentiate that. This is what science is bringing us. You couldn't have imagined that 10 years ago, but now you can. The future is looking better. It's exciting. And I would say the other fear is that, people say, well, wow, what would happen if I screened every year starting at 50? Well, you don't have to go very far, but to look at every other country in the world. I think Sweden starts at 45. Every other country starts at 49 or 50. And they screen every other year. The UK screens every 3 years. Their mortality rates are no different than ours. Lots of smart people have looked at this data and come up with a conclusion that this is weighing all the harms and risks, that these strategies are equally effective. What we're saying that's different is, well, gosh, we don't think one size fits all in breast cancer makes sense, because there are some people who we know are at high risk, and there are some people we know are really at lower risk. Why are we screening them the same? This makes no sense. And these are tools that we know that we can put into, into production today, which we have. That's what this trial is about. And by being followed carefully, you'll see it. And remember, screening is only one of the tools that we have. I think people have this mistaken notion that if a cancer is not detected with screening, that therefore it's a killer cancer. And if it is, that therefore your life is saved. That is not correct, right? That screening contributes some to a better outcome, but our medications and our ways of treating it really contribute the lion's share. And, we can do better when the cancers are found slower, but a lot of it's based on the biology. And we're not actually finding these fast-growing cancers with screening now anyway. We have to say, what can we do to make our current systems work better for the people who need it and need it now? And I think that's the notion. If what we were doing today was perfect, and every cancer found was a life saved, then we wouldn't need to change. But you contribute maybe 5 or 6% absolute benefit. It's not a big amount. It's one of the tools. But I think if we made those tools better and we used it to think about prevention, we could be much, much, much better. And I think these are the things that people need to understand.
So, about 20 years ago now, I think I have a girlfriend who I grew up with in the Adirondacks, and she had a double mastectomy. And she did it proactively because her mother, who didn't die of cancer, but got breast cancer, and then her sister died of breast cancer. So she decided with 2, children to not take the risk of losing her life. She didn't want to abandon her children. So she proactively had this done. And I think about her all the time because the courage that must have taken, was that necessary in her case?
Again, we don't know. Now we have the tools. We can't tell everybody, but we can tell now we know we can maybe explain 2/3 of the risk in these strong family histories. There's still some work to be done, and I'll get back to that in a minute. But if you inherit one of those mutations and that someone in your family has it and you have it too, you have a choice to make. And I will tell you that mothers of young children, frequently make that choice, because guess what? Our tools for doing those procedures and to doing them cosmetically have improved a lot. And partly because of this, because we wanted to make it palatable and more acceptable to people, where you can save all of the skin, including the skin of the nipple. Now, it's not perfect, but you have to say, gosh, do I want to face that risk? And I always say to people, is it about living or dying? Is it about ever going through the experience of it? I mean, even if we have a better treatment, are you willing to take that risk and think about being treated for it? And then you're worried about whether it'll recur. Or, is it that you hate the screening? And some people just hate the screening, doing something every 6 months. And other people will say, I don't mind as long as I screen every 6 months. Hopefully I'll catch it earlier. I'm going to be forewarned. So not everybody makes the same choice, and everybody needs to know that there is no one right answer. There's an answer that's right for you. But for certain people, it is absolutely the right thing. Their risk goes down to 1%, from 80% to 1%, or 3%. It is a big change. For someone who comes from a family where many, many people died, they may say, look, I have the chance to not accept that fate.
Yeah.
And, one of the things that we also have the ability to do, if we know who's got these genes, before people go ahead and give birth, you can actually do in vitro fertilization and pre-implantation genetics and tell which of the embryos have the mutation and who don't. And you can not pass on that inherited risk.
Wow.
Now, not everybody wants to do that, and that's fine. That's their choice.
Wow.
I will tell you, New Zealand pays for people who have inherited the gene for Huntington's chorea, BRCA1, BRCA2, and others. This will pay for 2 rounds of in vitro fertilization and pre-implantation genetics. I will tell you, that is a great and solid commitment to prevention.
Yeah, well, New Zealand
in
is
this country.
amazing.
People are crazy about that. And people are they better not try and take that right away from us. I'll tell you, these are modern advances that help everybody. One thing that I think is a struggle, when a mother has a daughter or a father has a daughter that has inherited a mutation, they feel a lot of guilt, that they feel like they've passed this on. But and sometimes it's a natural feeling and they just can't help it. But I always say is that, like, you passed on all these other things that, this is just one of the things we happen to know about. It's very hard sometimes for people to really get over that, even though it's not their fault. It's just something that we know about. But it's one of those things that we have to pay attention to, and pay attention to how people feel about it, and make sure that we provide the resources and support, for all that. But it's like knowledge is power. That's how we make the field better. We keep knowing about things and working on it and trying to understand, who needs more risk. Sometimes when we find in the 𝐬𝐮𝐬𝐜𝐫𝐢 study, someone who's gotten to the age of 60 and hasn't yet had a cancer, well, we know that risk from that particular gene is going to be lower. And now we know also that polygenic risk can actually inform us and help us make, give that combined information to women so they can make better and more appropriate decisions. And there are, in fact, I was at a conference in early September where Nellie Polyak was talking about, this notion of host in a different way. So it's not just the genes you inherit, but how your T cells work, the repertoire of your T cell receptor. Maybe that's something that puts a certain population at risk. But these are out of the box notions that really help us rethink cancer. Everybody doesn't have a risk for developing cancer, just as everyone doesn't have a risk for developing heart disease. So the more we understand what that is and who that is, could you imagine if we could figure out the 20% of the population who is really at risk, screen that group and leave everybody else alone? That's fantastic. There's a lot of stuff that we do inadvertently in the name of trying to prevent cancer. Think about this. We do all these biopsies, find DCIs, and the next thing you know, 25% of the people who have DCIs get bilateral mastectomy with far less risk than someone who's a mutation carrier. So we have to think about this, and we actually believe that using active surveillance and a screen for it with 3 to 6 months of therapy, you can tell who's really at risk for progression and who's not. There are better ways to do things, but we have to be willing to try it. It does take some courage to try something a little different. But if you don't try it, you're stuck doing the same thing you've always done. And last I checked, nobody I sit across from says to me, "Oh, wow, I love that option. That's great." But some of the new things that we're dreaming up, they're excited about and they want to try it. That's how we're going to make progress. And it does take courage from women, absolutely, who want something better for themselves and for their children and their mothers and friends.
So speaking of children, friends, family, this is a good segue into support. I'm curious, right, for the men who are watching this, what can men do, right, to give more support to women who are maybe at high risk or in fear and worried about, taking proactive measures? How can men get involved?
Well, there's a lot that can be done. whether you're a man, a woman, a friend, a sister, a mother, whatever support you provide. Number one, cancer is not an emergency. It is an emergency because you know about it. Risk for cancer is not an emergency. It's an emergency because you know about it. Do not panic. Take your time to understand what the situation is and what the options are, and to ask, are there clinical trials? Are there other things that I can think about? Is there a way that I can approach this where I can learn more information? Listen, ask when you're getting a consultation if you can record the conversation. We have something at our breast care center that Jeff Belcora and his colleagues that we have done. We have what we call a patient support core, where we help people create a question list. And then we record the conversation. We call them patient scribes, not physician scribes, so that people can listen to that conversation. We know that when you're panicked and when you're anxious, it's hard to hear. Be another set of ears for somebody. Help take notes. Recording that conversation is a good thing. If someone doesn't give you options, go find someone who will. There's no one right treatment for any of this. So there are options. And some people say, well, why isn't there one option? Because there's different approaches. If there was one perfect answer, everyone would do it, right? But there is often, choices among things where this might be a little bit better, but it might be a little more toxic. This might be, in the long term might be better. But again, also ask if there's ways in which you can start first with any kind of medicine. One of the exciting things that we've done in the setting of DCIS or in situ or precancer, again, my colleague Nola Hilton and I have, persist in thinking that imaging is a catalyst for change. By getting these breast MRIs, what we've seen is, gosh, some people have a focal mass, some people don't. Some people have what we call this kind of like a starry sky or a non-mass enhancement. And it's not the same. And when you do 2 or 3 to 6 months of whatever therapy you think is the right thing first, a lot of it'll go away. So I actually think that the cholesterol or the high blood pressure of breast cancer is going to be background enhancement. So the background or the enhancement on an MR, and maybe we'll find, maybe a non-contrast or on contrast mammography, we'll be able to see the same thing. If that is a risk factor, and especially if you're in that high risk category where you're being told to get those frequent tests anyway, and you show, we know that this is a risk factor, increases your risk 5-fold if you have the highest amount of background enhancement compared to the lowest. And if you take this medicine, it goes away. You know that you in particular are getting that benefit. That's why it's not so hard for people to take a statin. They take it and their cholesterol goes down. They take something to lower their blood pressure, or they do a lifestyle intervention to lower their blood pressure, and their blood pressure goes down. They can see it. So that's something we want to be able to find for women. And that is one tool, background enhancement. If it gets better, we know their risk is better. Yeah. Is lowered and this medicine is working. And, if one dose doesn't work, you can try another. These are things, this is the way in which now people are trying to move the field forward. It's very exciting, right?
And so surgery, unnecessary surgery.
Right. And, for some people, we think that maybe half the people don't need it. And there are other trials out there, like the COMET study, where people are being randomized to surgery versus not, that we're going to learn a lot about. My particular brand is I like to look and get the imaging first and try and say, how is that affecting it? What can I learn? How am I going to manipulate this and make it better? So it's just another way of doing it. So trials are really important opportunities, as I say, to get tomorrow's treatments today. Listen, learn, find opportunities. Don't panic. Don't feel like you have to make a decision right away, because sometimes the things that you say you want to do right away, 2 weeks later, people don't. I have a rule. I won't operate on someone who wants a bilateral mastectomy within 2 weeks of their diagnosis, because I find that over half of people change their mind.
Wow.
If you rush someone to the OR, you've not given them that opportunity to take a deep breath. Because sometimes people say the funniest, that to have these notions like, oh my gosh, I'm being punished for something I did, or,
Yeah.
this is terrible, I want this gone. But when they stop and I say, well, okay, I can do that, but what are you trying to accomplish? Are you trying to save your life? Because it's not going to make a difference in whether you live or die. Are you trying to avoid another cancer in the future? Might make a little difference, but not a lot. Or are you trying to avoid screening? And there it makes a huge difference.
Yeah.
But often when people realize those are the choices, they stop and I say, you need to think about it. And many, many people give it some thought and change their mind. And you have to allow for people to adjust. It's so upsetting to feel like, oh my gosh, my body has turned on me. Something terrible has happened. And they just need a chance to adjust, think about it, take a deep breath, and realize it's not always going to be that way. Time pressure is the enemy. You just need to take the time pressure off and realize your life does not hang in the balance.
Wow. This is
someone with a big bad cancer, it's not, you do not have, we can, if someone is young, one of the tragic times for a diagnosis of cancer is when people are trying to get pregnant and they discover a cancer. And if it's a fast growing cancer, chemotherapy can, especially if you're older, can rob you of that opportunity. But we can actually harvest eggs. You can stop, even if it took a month, you can have that month. It's not going to make a difference. Response to therapy is what makes a difference. And that we do first. That's why I'm a surgeon. I don't believe in operating first. Why? Because if you have a cancer that's going to kill you, it's not going to kill you because it's in your breast. It's going to kill you because it gets outside of your breast and takes up residence in some other organ. And the only way to find out what kind of response you have is to start that systemic response first, so that in due course, when you do operate, you'll learn, did your tumor respond? Did the growth rate go up? Did it go down? So now I have a second chance to figure out what to do. And in our 𝐼-SPY trial, we actually have 3 shots on goal. If the new exciting therapies make it go away, you're done, and you don't have to have all the toxic therapy. But if it doesn't, you're going to go on to the best thing for your particular subtype. These new classifications we've come up with, what we call our response predictive subtypes. And if that works, you're done, and you don't have to have 𝐟𝐸 based therapy. But if you still have it, then we need to push and do something else. And there we're going to start finding even better things to do that are less toxic.
wow.
But it's in my mind, it's a sensible approach. I'm trying to design trials that people want. I had a patient a few years ago who had this terrible triple negative breast cancer. She was 34. And I was excited because she got assigned to one of the new immune checkpoint inhibitors. And I was like, oh, that's going to make her tumor go away. And it did not. And she said, you have nothing for me. You have to do better. Laura, you have to do better. And she died in less than 2 years.
Wow.
And you know what? She is right. We have to do better. That is why I'm pushing forward. And that is why we cannot stand still. When it works, it's great, but when it doesn't work, it is not okay. And we cannot design we have to imagine what we think the future of care should be and design our trials to get to that future. And we have to have some urgency. We have to have urgency. People don't have 10 years for us to get our act together. The person who has that bad disease, they need the better options today. And so when I see new drugs that have passed their safety test that look exciting, don't wait 5 years before they get to the people that need them. Test them now. Test them now.
Yeah.
That's what we're trying to do.
So, it's interesting because this holistic approach that you're taking, and obviously breast cancer is your specialty, but, when you look at other areas of medicine, where else is it broken where they could use similar approaches to the wisdom study that you're doing in your work? Where could this be used as a model for other areas of healthcare?
These notions are very scalable. During the pandemic, we put together a phase 2 trial for people with respiratory distress in COVID. And we demonstrated that we could put a network together very quickly and test 10 drugs rapidly, learn and try and figure it out. And one of the things that we've learned from that is, guess what? We probably shouldn't treat respiratory distress as if it's just one disease, because it's probably not. There's hyperinflammatory and less, and people have different risks at different times. So we have to get to a place where we can bring those boxes in and profile people at the start. But we need people to say, wow, I want to be part of trials. I want to do something better. We have to design trials that people want to be part of. Because the next pandemic that comes, your lungs are the last,
Right.
refuge. And we have to solve this problem, not just for COVID, but for anybody. Flu kills a lot of people too. So that's sort of where we're going. But truly, these are scalable notions. We probably can apply what we've done, in breast cancer to all cancers.
Yeah.
But every disease is not one disease. Figure out how to profile and continue to push on profiling better and better from the start. Start thinking about assigning therapies based on that profile and testing so that we can advance the field. Precision medicine. That's what it's all about.
Yeah. Precision medicine and personalized care, which has
Correct.
really never been the order of the day.
Yeah. And if someone comes in and they are really suffering from one of the treatments, okay, well, you have to make a change. You have to listen to your patients. You can't just say, okay, you have to be on this and that's it.
Yeah.
No, if they can't tolerate it, you have to be creative and find better ways, better things that people can do. And that's why we have to have more options. And we have to have, the aromatase inhibitors are hard for people to take for long periods of time. Great. We just found someone who's shown that actually this guy 𝐬𝐮𝐬𝐫𝐞, who showed us the baby TAM was just as good as regular TAM, along with my colleague Per Hall in Sweden. 3 days a week of exemestane looks like it suppresses estradiol the same as every day. There are trials from Korea that showed that 9 months on, 3 months off, same thing. And people are suffering and having joint aches. Find ways to make it less. The FDA is also pushing on this notion of not maximum tolerated dose. That's how we've always developed drugs, but minimum effective biologic dose.
Yeah, much more sensible.
So sensible, because if you can't take the drug, you can't get the benefit.
Right.
So if you have something that works, but people can't take it, you're not going to get the benefit, and it doesn't matter. If people are having trouble with it, figure it out.
Yeah.
And don't figure it out by doing hundreds of thousands of patients at a time. Try and figure out what that intermediate marker is. Circuit, even if it's not perfect, it's a lot better than waiting 10 years for every new knowledge to turn. It's too much. So this is the notion: have urgency. Think about biology. Think that, that everybody isn't the same. Think about host factors, not just the tumor itself. These are the common notions that allow us to think about the systems that affect whether or not you are going to succumb to a disease or not. And these are the different levers you have to make change. And that's, what makes the science exciting, and the ability to tailor to a particular person's situation. That's the art of medicine. And that's what makes medicine such an incredibly wonderful field. And such, I love what I do. I feel so incredibly privileged to take care of people at their most vulnerable time, to use my brain to try and think about how I can solve problems, how I can run and design better trials. It's very meaningful work on a very personal and individual level, and on a population level. And I think that's what a lot of us go into it for, to make a difference.
Make a difference. Do you have any parting words for people who are listening? Obviously we'll put on the subsequent pages how they can get involved in the trial, where to go to sign up, but any additional words of wisdom, insight, advice for people listening?
So I would say again, clinical trials are tomorrow's treatments today. As a person, you should always be wanting to demand better and know what your options are. You don't have to do or participate in a trial, but you want to know what they are. I think for anyone who's had cancer or had a diagnosis, don't panic and don't feel, remember, you're not going to always feel that way. And people find resilience that they never thought they would have. And if you fear of recurrence, don't let that ruin your life. Think about the fact that you're taking the treatments to return yourself to a life you want to live. And start by thinking about, now that I know that I've had this, what am I going to do to remind myself that tomorrow is the next day of the rest of my life? And what do I want to do differently? And what fabulous thing I always recommend to people: plan something exciting that you've always wanted to do that maybe you wouldn't have done had you not had this diagnosis, and use that as the first day of a release from the craziness of the cancer world, and to allow you to go forward. Don't allow the fear of cancer to destroy the life that you want to live, because that's what you went through treatment for. And I think people want certainty, but life is uncertain. Life is uncertain, and we don't really have all the control that we would like to have. This is just one of the things that you know about that provide risk. Look both ways before you cross the street, because you never know what's going to happen, right? So just remember, you can let this go. You make the best decisions you can and move on.
Yeah, this is beautiful advice, Laura, really. I mean, it's just amazing advice. And we went in directions I didn't think we were going to go to today, and some serious, and some urgent, but some not so urgent, and really focusing on the preventative care that we can do, the micro medicine, right, at a level of let's get it precision medicine and personalized care, and that's where we all need to go.
And what I say, the wisdom study is every woman's opportunity to say, you know what, I'm not satisfied with where we are. I think we can do better. I want better for myself, and I'm going to be part of the movement of women that's going to make the future better for myself and for everybody else.
Yeah, bravissimo. Well said. Well said. Thank you so much for spending this time with us today. And I know this conversation is going to help many, not just women, but many people who are listening, because all of us have been touched by cancer, all of us. So yeah, thank you so much.
You're welcome. Well, thank you for having me, Renee.